Thank you very much for the invitation, Axel and David. Such a great meeting, nice city, but I would say that for my standards, this is freezing. Completely, even inside the room. So I'll try to update in a very summarized way, what's new on the management of neuroendocrine tumors. And as you know, we have 3 different types of NETs, and this is makes completely different treatment decisions and prognosis. So those patients who have well-differentiated tumors with a Ki-67 immunochemistry expression up to 3 are called the G1. So these are the better prognosis group. Then you have the G2 where they're still well-differentiated, but the Ki-67 goes from 3 up to 20. And then you have the poorly differentiated ones with the Ki-67 above 20%, and these patients have a poor prognosis, but they tend to respond better to chemotherapy. And because of such a variety, we know that there are many different therapeutic options for these patients. And because many of these patients live for long periods of time compared to gastric cancer, pancreatic cancer, they generally receive different types of treatments, including surgery, local regional therapies, and etc. For the purpose of this talk, I'll be focusing on systemic treatment. So what's new with the oldest type of treatment, the somatostatin analogs? So the landmark trial, the PROMID, published a few years ago, proved that the somatostatin analogs do have a antiproliferative effect on NETs. So this was the PROMID trial that randomized patients with Midgut NETs to receive either placebo or octreotide LAR. And then the study was positive with a time to progression improvement of about 6 months for octreotide. And then what is new about this strategy is the CLARINET trial, which tested a similar question. So what is the antitumor effect of lanreotide, which is another type of somatostatin analog, compared to placebo? If you see here the PFS, it looks better than the PROMID, but it's hard to compare studies. Well, it's important to know that patients in both trials did not have to have progressive disease to get into the trial. So many of these patients already had stabilization for a long period. That's what makes the curve so nice. But the difference with the CLARINET is that they included about 40 to 50% of patients with pancreatic NETs. And these type of patients were not studied in the PROMID. And these you can see the curves. So it's, of course, it's a subgroup analysis. The trial was not powered to look at the pNETs, but we can see clearly that there is a benefit for this group of patients. So it validates the use of somatostatin analogs and pNETs in a prospective way. And there is now a new type of somatostatin analog, is pasireotide. It has a higher affinity for several types of the somatostatin receptors. And pasireotide has been tested in first line in metastatic NETs, most of it Midguts, and treatment naive. So this was recently published. The primary endpoint was progression-free survival. And as you can see here, median PFS of 11 months, so not very impressive. But the main thing is the toxicity. So a lot of patients developed a grade 3 hyperglycemia. So probably this is not going to move forward. And just recently, a couple of weeks ago, in the big pNETS meeting, which is the Neuroendocrine European meeting, there was the oral presentation of this trial that was really awaited, is the COOPERATE-2. The COOPERATE-2 randomized patients with pNETs to receive Everolimus as the standard arm, compared with Everolimus plus pasireotide. So there was this expectation that if we combine both agents, we will improve the efficacy. And then, as you can see here, there's more tumor shrinkage on the group of the combination, but PFS, which was the primary endpoint, did not change. So the study was negative. I am one of the co-authors of the study, and we had the experience to treat some patients, and it's really toxic combination, especially with the hyperglycemia grade 3 and sometimes 4 adverse event. And what about target agents? So as you know, there are two phase 3 trials controlled by placebo for pancreatic NETs. Both were published in the same issue of the New England a few years ago. And they had very similar designs and very similar results as well. So both showed a PFS of about 1 year compared to about 6 months for the placebo. But these patients had progressive disease to get into the trial, so it really shows that both Everolimus and sunitinib do have an effect in pancreatic NETs, and then both drugs have been approved worldwide. And the good thing is that when you look at the hazard ratios for first line versus further lines, you see there's not a big difference. So using either sunitinib or Everolimus upfront or after chemotherapy or somatostatin analog, it doesn't seem to alter the benefit. So one can argue that you can use in first line, but you can also use after chemotherapy, for example. And the Everolimus study, which approved this drug for pNET, now has been updated for the overall survival analysis at ASCO GI, and this is the results. So as expected, there was no difference in overall survival, although you can see that numerically it favors Everolimus. And this is still not positive after adjusting for prognostic variables, but we have to consider that, you know, nearly more than 80% of patients on the placebo arm crossed over to Everolimus, so it's, you know, because the post-progression survival is long, it's hard to detect survival gains in this setting. And what's the new strategies that are being developed in pancreatic NETs? So the combination of an mTOR inhibitor with an antiangiogenic agent. So this is the phase 2 that combined Temsirolimus, which is another mTOR inhibitor, with Bevacizumab, with patients, 58 patients with well-differentiated pNETs, all patients with progressive disease, and most of them treatment naive. And surprisingly, they showed a response rate, objective response of 41% and a median PFS of 13 months. Of course, this is a small trial, but it shows really encouraging results, especially because we know that the response rate with Everolimus is about 1 to 2%. This is the curves. And this led the CALGB trial, which is the question, so pay attention to the results. They're going to, is randomizing nearly 180 patients to the combination of octreotide and Everolimus with adding Bevacizumab. So it's a new strategy of combining both, including the octreotide. And what is new about treatment for functioning tumors? So for decades, we've been using somatostatin analogs for the treatment of functioning tumors, mainly carcinoid syndrome. But recently, we have had some news, interesting data. The largest study conducted in functioning NETs is probably, so far, is the RADIANT-2. So the RADIANT-2 randomized functioning tumors, most of them midguts with carcinoid syndrome, to receive the standard treatment of octreotide 30 milligrams. So these patients have to have progressive disease to get into the trial. So many of them were already resistant to lower doses of somatostatin analog. So standard arm, 30 milligrams. The experimental arm combined Everolimus. And then this study has some a number of methodological problems. The primary endpoint was PFS, evaluated by central radiological review, but then there was a great disparity when investigators defined progression based on symptoms and not only on the CT scans. So in the end, there was a lot of censoring. Many patients were censored before they reached the event, and then the study lost power to really evaluate its primary endpoint. So based on the primary endpoint of central radiological review, the study was negative. But if you look at the local investigators' assessment, it's clearly positive. But it has not led to regulatory approval in many countries. In Brazil, it is approved, so it's in a label. And it's interesting because many patients had, well, most patients had carcinoid syndrome. And then in clinical practice, when you add Everolimus to octreotide, you really see a great benefit in terms of controlling the symptoms. So it seems that Everolimus also has not only anti-tumor activity, but also anti-secretory properties. And this is a new agent that has been published and showed as abstract forms. Is the Telotristat etiprate is an oral inhibitor of serotonin synthesis, and is being developed specifically for carcinoid syndrome. So there's 2 phase 2 trials, one single one, as you can see, and another randomized one. Generally, what the outcomes are is that patients decrease diarrhea. It seems that the drug didn't have much effect on the number of flushings that patients had, but mostly on the bowel movements a day. And what about silent NETs? So this is a great challenge because there's not good evidence out there to define which is the best strategy. So there's more studies. This first one, as you can see, mainly in colorectal NETs, showing promising results with Everolimus, but it's not randomized, so it's really hard to say. But this is going to be answered by the RADIANT-4 trial, which has just completed accrual, and probably is going to be presented this year still. It's a phase 3 study comparing Everolimus versus placebo, and this is probably the last NET trial that has a placebo-only arm. And this is specifically for silent NETs. And at ASCO GI this year, James Yao presented the baseline characteristics, and there's not much to see, but what I draw your attention is that 1/3 of patients have lung NETs. And lung NETs, and although it's rare in clinical practice, but it is a great challenge because we really don't have no good evidence out there to guide the treatment. So we're going to have the results specifically for the lung subtype. And what about chemotherapy? Well, chemotherapy is one of the oldest treatments for NETs because there was nothing else before. And it doesn't work well for midguts. It has good activity and is consistently shown to have response rates of around 30% for pNET. What is new in chemotherapy is something that is now in a fashion, is the combination of capecitabine and temozolomide. And this also has been presented at ASCO GI last year. But what is interesting is that, again, it shows a response rate of about 30% in pNETs. But interestingly, it shows a good response rate for the carcinoids, which are usually considered to be chemo-resistant. But I know, it's just a small study with mixed types of NETs included. But then there's a big trial, European trial testing, then in a prospective way, randomized fashion, what is the role of temozolomide, capecitabine, versus only temozolomide? So do we really need the combination, or just one of the agents is enough? So this is still enrolling, and we're going to get the results in the next years or so. Another interesting strategy that has recently been published is this French study, the BETTER trial. So they use the AVEX strategy of combining capecitabine and bevacizumab, and this is only for midguts. So 80% of patients, most of them were midguts, and they had progressive NETs. So again, because midgut tumors are considered to be chemo-resistant, it's interesting, the results which shows a partial response of 18%, so it seems to be a good combination. We are not sure if it's capecitabine the main point here, but probably bevacizumab is adding efficacy, with a median PFS of 23 months, which is promising too. And what about PRRT? I know PRRT is not approved in the US, is not approved in Brazil, so we do not have good access to this type of treatment. But once we can treat a patient with PRRT, we see it's a good treatment. I mean, there's low toxicity, and most patients respond to the treatment. They have to be, of course, selected for the for the well-differentiated ones, but it seems to be a good strategy. And this is the first US experience. So most of the experience published in the literature come from Europe, especially for the Dutch group from Rotterdam. But this is the first US experience. So it's a phase 2. So better, I mean, we have larger series, but they're all retrospective, which there's a huge selection bias. So this is a phase 2 with lutetium-177, 37 patients with progressive NETs, G1 and G2, and they received the standard doses of PRT. The response rate was nearly 30%, and this is only, and it seems to improve clinical conditions and quality of life. So just, validated that PRT is a good treatment option for patients with NET. And then there's this phase 3 trial randomizing patients to either lutetium or octreotide, LAR. And this is probably going to be a positive study because patients have to have progressive disease prior, and they had, if they're getting octreotide 60 milligrams, so they had progressed 30, 40. So probably the 60 milligrams is not going to add, long-term benefit. So it's very likely that lutetium is going to be the winner here. So what we conclude about, new things about NET in 2015 is that, well, the knowledge continues to evolve. Now we do have phase 3 data. We can, and they are getting matured. We have more information on survival and et cetera. But of course, there's numerous gaps. I mean, these are a heterogeneous group of patients, and sometimes when you have the patient in front of you, it's not only evidence-based medicine, but more on the feeling of which treatment you're going to start. We don't know the best sequence, and probably I'm not sure if this matters, because again, these patients tend to live for a long time, and they're probably going to benefit from all the treatments available. Unmet needs, still, lung NETs, it's very difficult to know what's best for them. And refractory carcinoid syndrome, which is something that is not uncommon and is also very hard to manage to patients. But I'd like to finalize saying that when we see this sort of curves, of course we look directly to the proportion of patients who get tumor shrinkage. We look at it in a positive way. But I think we should really focus on this on this part of the curve, showing that although many patients benefit, many of them don't. And you really have to find out which patients are these so we can, increase the benefit for those who are going to get it, and then not use futile treatments for those patients who would not get any benefit, and of course, just a waste of resources. Thank you.